Hello, everyone. So as Karine mentioned, I'm Dr. Chatterjee. I'm a rheumatologist at Cleveland Clinic, main campus in Cleveland, Ohio, where I direct the Scleroderma program. And I am honored to be here today. I thank the National Scleroderma Foundation for inviting me to speak uh, and also for organizing such an excellent program. So it is a pleasure to be here with all of you today. I hope there will be time for questions at the end of this talk. So you are welcome to write them down if you want, and we can get to them later. There's a lot to cover. I will try to be done on time, but I understand there is nothing after this talk today. So if I go over a few minutes, hopefully I'm allowed to do so. Okay, am I not? Maybe. All right, thank you. So my task today is to discuss musculoskeletal manifestations of systemic sclerosis. So these are my disclosures, but I have no actual or potential conflict of interest in relation to this presentation. So let's go over some definitions. I like to go, with the basics first, and just a little bit of anatomy lesson. So because, people have different ideas about what musculoskeletal system is. So let's get started with some definitions. From a cell, which is the smallest structural unit of living matter that makes up all living organisms and tissues of the body. And what is a tissue? It is a group of cells which have a common structure and function in our body. And what is connective tissue? Because that's what we are going to be talking about. It's the tissue that connects, separates, and supports all other types of tissues and organs in the body. So it consists of cells surrounded by an extracellular matrix, which is a structural support network made up of different proteins, sugars, and other components. What's the musculoskeletal system? So that's my task today. So manifestations of scleroderma affecting the musculoskeletal system. So the musculoskeletal system consists of bones, ligaments, tendons, cartilage, joints, which comprise of a joint capsule lined on the inside by synovium. We will be talking a lot about synovitis, so you would like to know what synovium is. And then we will be discussing that in the next slide, and also muscles. So the musculoskeletal system provides the body with its basic structure, shape, support, stability, posture, and the ability to move. So the Greek word arthron means joint. So why do we call it arthritis, joint inflammation? This is the derivation of that word. So arthritis is derived from the Greek term inflammatory disease of the joint. Anytime anything ends with itis, it means inflammation, like appendicitis, cholecystitis, cellulitis. So here we are talking about itis of the arthron or arthritis. It causes pain and can lead to structural damage. So these are some important components of the musculoskeletal system. As I said earlier, so what is bone? Bones are made of connective tissue reinforced with calcium and specialized bone cells. Joint is the point at which two or more bones meet. Joint capsule, it's the firm connective tissue. It's kind of firmer compared to what's inside the joint. That seals the joint space and provides joint stability by limiting movements. Synovium, which is the connective tissue that lines the inside of the joint capsule. And it gets inflamed, and that's what we call synovitis. Articular cartilage, or cartilage, that soft tissue that lines the ends of bones that forms a joint. And we have a nice figure in the next slide. So synovial space is the joint cavity. Muscles are soft tissues made up of many stretchy fibers or contractile elements. We have more than 600 muscles in the body. What is a tendon? It's a band of connective tissue that attaches muscle to bone. And what is a tendon sheath? It is a covering of the tendon. It's a membrane-like structure that surrounds the tendon, which allows the tendon to glide smoothly inside this covering. What's a ligament? It's a band of connective tissue that attaches bone to bone at a joint. So when it's muscle to bone, it's a tendon. When it's bone to bone, it's a ligament. Enthesis is the point of attachment of a tendon or a ligament or a joint capsule to bone. So that junction between tendon, ligament, or joint capsule attaching to bone, it's called enthesis, because we will talk about enthesitis or inflammation of that junction. And then bursa, it's a fluid-filled pad or sac that acts as cushions at the joints. So going step by step, the epiphyseal bone, which is the end of a long bone, is called epiphysis. So that's what the epiphyseal bone is. So this is the figure of a joint, and I will be showing step by step what the different components are. So epiphyseal bone, then we have the joint capsule, which is the outside layer that you can see. See whether I can use my pointer. It's a little hard from this angle. That's the joint capsule. And then we have the articular cartilage, which is the lining of the bones are covered with cartilage inside the joint. This is softer compared to bone. And then we have the synovial cavity, or the space where synovial fluid can accumulate. When you have a effusion in a joint, that's where the fluid accumulates. We have muscle at that end here. And so a muscle is attaching to the bone with a tendon here. And then we see the ligament, which connects bone to bone. And we have enthesis. You can see as they're attaching muscle to bone or ligament to bone. And then we have the bursa. One other structure that is important, which is a tendon sheath, which is a covering of a tendon. This is relevant when we are going to talk about carpal tunnel syndrome in scleroderma. There is inflammation and fluid accumulation in the tendon sheath that will be compressing the median nerve and the wrist, causing carpal tunnel. So this is a cross-section of a human joint. And as you can see, that's the bone there. And the cartilage is covering it on each side. And that's the joint capsule on the outside of it. So various parts of the musculoskeletal system can be affected in scleroderma, and we are going to talk about those in detail later on. But this is just a list of things that can go wrong in the musculoskeletal system in scleroderma. So joints can be affected. Arthropathy means any disease of joints, anything to do with joints. Pathy is just a general term, but when it gets inflamed, it's called arthritis. And when you have joint pain, it's called arthralgia. Algia means pain, like analgesics. So muscles, myopathy means any disease of muscles. But when this is of an inflammatory nature, where there is a role for immunomodulatory therapy, that's called myositis. As I said, itis means inflammation. And muscle weakness is also a feature of muscle disease. And also muscle pain can sometimes be seen. So algia, as I said, is pain, so it's called myalgia. So bones can be presenting, the involvement of the bone can be in different forms. Acroosteolysis is a common manifestation of scleroderma. Sometimes late in the course of disease, there's a loss of bone at the tips of fingers and toes from lack of blood supply. That's called acroosteolysis. Acro means fingers and toes, osteo means bones, and lysis means the bone is dissolving. Osteoporosis is more common in scleroderma patients compared to the general population, and we'll talk about it. The next one is called avascular necrosis. It is bone death from lack of blood supply. It's a rare manifestation, so I may not have time to discuss that particular manifestation, but it does happen in some patients. Tendons can be affected in the form of tendinopathy, which can manifest as tendon inflammation or tendinitis, or tendon sheath inflammation, which is tenosynovitis. So the tendon sheath is lining by the same synovium that lines a joint, so it's called tenosynovitis. And then tendon friction rubs. It's another manifestation that is seen early in the course of some patients with diffuse scleroderma. Then we will talk about bursitis. It's a fluid-filled pad or sac that cushions between a tendon or ligament and bone. Sometimes a bursa can be under the skin as well, like prepatellar bursa in front of the kneecap, or olecranon bursa over the elbow. And that can also get inflamed. And then the other manifestation, sometimes early in the course of the disease, is flexion contracture. So patients have difficulty straightening their finger, they're curled up in a flexed position. And then calcinosis, another difficult condition, extremely difficult to treat, is also a musculoskeletal manifestation. Fibromyalgia, which can coexist, it's a very common condition, and can coexist with other autoimmune rheumatic diseases. In fact, it's been found fibromyalgia is more common among patients with autoimmune rheumatic diseases, so can also be seen in patients with scleroderma. So the manifestations of musculoskeletal involvement in systemic sclerosis will typically lead to pain, swelling of the joints, stiffness, weakness, decreased range of motion of the joints, compromised function of the joints. Also, deformities can develop and fatigue, which comes with it. And the consequences could be quite devastating: depression, anxiety, impaired quality of life, and disability. So we will go over the different aspects of the musculoskeletal system that can be affected in scleroderma. So first of all, we will talk about arthropathy or arthritis. So as you can see, this is a patient with deformities of the fingers. They're going outwards, called ulnar deviation. So the prevalence of arthritis in scleroderma is variable based on the study that was conducted, anywhere from 24 to 97% of patients based on the study, and the references are at the bottom. So early musculoskeletal manifestations of scleroderma include joint inflammation or synovitis, joint contractures, which I mentioned earlier, and these tendon friction rubs. And they tend to correlate with the severity of disease and with high degrees of systemic inflammation. And the joint inflammation and tendon friction rubs are independent risk factors for disease progression in scleroderma. So they are more commonly seen in patients with diffuse disease, especially tendon friction rubs, and not so much in limited scleroderma. And joint involvement is also associated with disability and poor quality of life. And the sad thing about musculoskeletal manifestations is, though it is quite prevalent in patients early in the course of the disease and throughout the course of the disease, the treatment of inflammatory arthritis in scleroderma has not been studied rigorously in randomized studies. So we are paying attention to interstitial lung disease, pulmonary hypertension, rapidly progressive skin thickness, even kidney disease, but two areas that do not have good studies or proven disease-modifying therapies. That means therapies that alter the course of the disease. One is the musculoskeletal manifestations. The other one is major gastrointestinal involvement. No proven disease-modifying therapy. So arthritis-specific outcome measures have also not been established, which are well established in some other aspects of the disease. The laboratory investigations. So when you're going to see somebody with inflammatory arthritis, rheumatoid factor can be present in 28 to 30% of scleroderma patients. It's a blood test that you order. It is a non-specific test, however, so isolated presence of rheumatoid factor in the absence of the next antibody called anti-CCP antibody is not suggestive of rheumatoid arthritis in all patients. On the other hand, antibodies to CCP or cyclic citrullineated peptide, also known as ACPA, is associated with concomitant rheumatoid arthritis, and it is seen in 1 to 5% of scleroderma patients and predicts the development of bone erosions. So localized bone loss that occurs from inflammation-induced bone damage, that's what called erosion, that can be seen in patients with CCP antibody, but not necessarily just an isolated positive rheumatoid factor, which can be seen in about 30% of patients. In inflammatory arthritis associated with scleroderma, inflammatory markers can be elevated, like sedimentation rate and C-reactive protein. And if the fluid had to be drained from a swollen knee or any other joint, it would show signs of inflammation with high white blood cell count in the fluid. And also, sometimes this is rarely done. If a biopsy was obtained from a joint that is inflamed, it might show evidence of inflammation. X-ray findings only show changes in the bones, but not in the soft tissues. So of all the different imaging modalities to look for evidence of inflammatory arthritis. X-rays are probably not as helpful early in the course of the disease. It only show what we call osteopenia around the joints or increased radiolucency of bone from effect of some circulating mediators of inflammation. Joint space narrowing can be detected because that cartilage that I showed you gets thinner with ongoing inflammation, and the two bones get closer to each other. You can see that as joint space narrowing, and erosions can be seen. But ultrasound, musculoskeletal ultrasound, it is much more sensitive in detecting synovitis or inflammation. It also picks up changes in the soft tissues that will be missed on the X-rays. So soft tissues including joint capsules, synovium, tendons, tendon sheaths, etc. And by far the best imaging modality, even more sensitive than ultrasound, is detecting subtle abnormalities that may be missed on X-rays, such as changes in structure of the bone and soft tissues, joint capsules, synovium, tendons, tendon sheaths. All of that could be picked up on an MRI scan. That's not likely to be picked up on an X-ray, because X-ray, as I said, only shows bone and not so much the details of the soft tissues. So this is a normal hand X-ray. As you can see, the joint spaces are well maintained. These are called the metacarpophalangeal joints. These are proximal interphalangeal joints, and this is the wrist joint. Multiple bones are there, and all of these joints can be affected. So the joint involvement or arthropathy in scleroderma could lead to pain and stiffness in the joints, which is very commonly seen in patients. But some patients do develop joint inflammation along with pain and stiffness, which is called arthritis and synovitis. And that is more responsive to anti-inflammatory therapies because it is a result of inflammation of these joints. So this is a patient with scleroderma who's seen early in the course of the disease. You can see this swollen, puffy fingers. Patient is unable to straighten the fingers, and there's significant pain and stiffness in these joints, the MCP or metacarpophalangeal proximal interphalangeal joints. It's thought to be a deep fibrotic process involving joints and tendons in these patients. So the MRI scan here also might show pathology. Here you can see MRI scan of wrist showing abnormal marrow signal over there in this bone called the lunate bone, which is very characteristic in patients with scleroderma affecting the wrist. And you can see the increased signal or the whiter color that is indicative of inflammation of the bone. An intense signal is seen particularly affecting the scaphoid bone up here. And then this is the radius bone also showing similar changes. Ultrasound, you can see erosion. So you can see that's the intact bone, but here there is a hole in the bone called an erosion. So the ultrasound signal goes directly through it. So they have two views, a longitudinal view and a transverse view. And you can see it in both planes. And the last one here is ultrasound scan of a MCP joint, which is the finger knuckle joint that shows synovial thickening and synovitis. So this was a study that was published in 2013. So it was very commonly found that patients with scleroderma get involvement of the wrist joint and the carpal bones. So there was evidence of erosions in 87% and bone marrow edema in 37%. 68% showed evidence of synovitis. So in fact, this is a very common manifestation if you're using the right imaging modality. So the low-grade arthritic changes are frequent in scleroderma, and the distribution indicates it's not just inflammation, but ischemic mechanisms or inadequate blood supply probably plays an important role in the joint involvement in scleroderma. So this is a patient of mine who was, somebody have been following for a long time. And as you can see this, if you remember the normal hand X-ray that I showed earlier, here there is significant arthritis affecting the distal interphalangeal joints. And also you can see it affecting the base of the thumbs bilaterally. And also the wrist architecture looks quite distorted. Those carpal bones are kind of fuzzy here. You cannot make out the margins over there. So there are patients, in addition to those who do not have concomitant rheumatoid arthritis, they only have scleroderma-associated inflammatory arthritis. But it can also coexist in some patients with seropositive rheumatoid arthritis. I have quite a few of these patients who develop, unfortunately, systemic sclerosis for a long time, and then more recently, on top of it, developed seropositive rheumatoid arthritis. So they have a positive rheumatoid factor, but also they have the more specific anti-CCP antibody. So this is what rheumatoid arthritis does. You can see the swelling of the MCP joints in this patient. And also you can see the deformities in the fingers. This is called a swan neck deformity, the little finger, and that's called a boutonniere deformity or a button hook deformity. These are changes that you typically don't see in scleroderma, but you see it in patients with rheumatoid arthritis, long-standing, not adequately controlled disease. Another patient, and you can see these bumps on the knuckles called rheumatoid nodules. They also appear in patients with rheumatoid arthritis, but not in scleroderma. And the X-ray also shows erosions and significant joint damage in this patient. This is a patient that I have followed for maybe 15 years. So these are X-rays in 2017. She only had scleroderma then. Then in 2022, as you can see, she in the meantime did develop rheumatoid arthritis, and now you can see a significant joint damage. So you can see I'm just highlighting those. The wrists look relatively normal here, and the finger joints look relatively normal. But in the second image, you can see the significant arthritis causing destruction of the carpal bones, which, as I said, is very characteristic of scleroderma. But this patient actually has rheumatoid arthritis. And also see these joints compared to that in these 5 years, she had significant changes that have accrued. And this is regardless, we have been aggressively treating her, but this disease progressed relentlessly. And this is the shoulder joint. You can see significant arthritis there. The bone is touching. And here it's the elbow joint of the same patient. The humerus, which is this bone, is hugging the ulna here. And you can see there's no joint space. So in addition to rheumatoid arthritis, patients can also develop osteoarthritis. It's a common condition, and you can see it in the general population, but it can also affect patients with scleroderma. And these bony bumps you can see are called Haberden's nodes. Similarly, here you can see bumps. Those are called Bouchard's nodes. So this is something you see. And if you took X-rays on those patients, you see these erosions on the distal interphalangeal joint. So it's called erosive osteoarthritis. It's an extremely painful condition, no proven therapy. It's more of a mechanical rather than an inflammatory process, but can concomitantly be present in patients with scleroderma. And sometimes it's hard to tell the difference. Is it scleroderma-associated inflammatory arthritis, or does the patient have an erosive osteoarthritis? And that will dictate the treatment. Moving on to muscle disease. Are we good with time? Okay. Muscle disease or myopathy, myositis. So muscle disease in scleroderma, more often it's a bland condition, bland non-inflammatory myopathy. That means if you did a muscle biopsy, there'll be some scarring of the muscle fibers, there'll be some lack of blood supply, some ischemic changes, but the inflammatory muscle disease, which is called myositis, is much less common. So a bland myopathy that results from muscle fibrosis and ischemia with or without elevation of the muscle enzymes. So when somebody has muscle disease causing muscle damage, whether it's a result of inflammation or just from fibrotic process, the muscle enzymes can go up, which is the main one that we check are CK and sometimes aldolase. So they typically may have mild muscle weakness, this bland form, which is much more common early in the course in patients with diffuse disease. Exact prevalence is hard to detect in this subset, but there's a less commonly but much more seriously affected muscle disease, inflammatory myopathy called myositis. It is seen in 10 to 15% of patients with scleroderma, and the antibody is typically associated is anti-PM-SCL antibody, which is polymyositis scleroderma overlap antibody. And also you can see it in RNP antibodies, which is typically seen in mixed connective tissue disease, U3 RNP and anti-COO antibodies. These antibodies tend to be mutually exclusive. So if you find one antibody, we don't keep looking for others. So if the common ones are already positive, we don't order those less commonly encountered ones. But sometimes in patients with myositis, it's helpful to do those antibodies because these patients tend to respond to immunosuppressive therapy as opposed to just supportive therapy if they have the bland myopathy. It's common in patients with diffuse scleroderma as opposed to limited. And symptoms include muscle weakness that causes difficulty getting up from a chair or sitting up from a lying position or raising the arms. Patients may also have difficulty swallowing because the muscles of the esophagus and the oropharynx, the upper part of the esophagus and the oropharynx is similar to skeletal muscle. It's called striated muscle, whereas the lower part of the esophagus, which is more often affected in scleroderma, that is lined by smooth muscle. So when patients have myositis along with their scleroderma, the esophagus can be affected at the entire length of it. The upper part could be from the myositis part and the lower part of the esophagus from the concomitant scleroderma. So elevated muscle enzymes usually accompany myositis, as I said, CK and aldolase. And studies have shown that aldolase seems to be a better predictor of myositis compared to CK, which can also go up in the bland form of myositis, bland form of myopathy. The EMG is an electrical study of the muscle, may be performed. It's not a very popular test because it's painful. Patients don't often like to go through this. And we can get all that information on a muscle MRI. It tells us whether there's muscle edema or inflammation of the muscle. It will also give us an extent of the muscle that is affected, which muscle groups are affected, and what's the extent of it. And it will also help us determine if I were to do a muscle biopsy, which particular muscle should I go after? The one that lights up on the MRI might be the one that will tell us what the pathology is. So a muscle biopsy is necessary to differentiate between bland, non-inflammatory scleroderma myopathy that is more common that I mentioned versus inflammatory myopathy or myositis and the significant muscle damage. So if somebody had long-standing myositis not treated, some permanent muscle damage happens. And what tends to happen is called fatty replacement, where there is permanent muscle damage and aggressive immunosuppression is unlikely to be helpful. It increases the risk of side effects from this aggressive therapy. And there is a correlation between myositis and scleroderma cardiomyopathy. This is also to keep in mind. Some patients do have heart muscle involvement. So those who tend to get muscle involvement of the peripheral muscles of the arms and legs also are at a higher risk of cardiac involvement, heart muscle disease. So if you want to ascertain that, the lab test that should be ordered is a troponin, because that doesn't go up with peripheral muscle disease, but it's specific for heart muscle involvement. You can also get an EKG and an echocardiogram to see how the heart is functioning in these patients. So this is a patient showing, it's a muscle MRI in this 57-year-old male with rapidly progressive diffuse scleroderma. The creatine kinase or the muscle enzyme is very high. Normally it's up to 200. Here it is 2,161. And you can see the changes on the MRI, which shows diffuse, markedly increased signal of the fatty tissue under the skin, which are the small arrows, like here. I can hardly see the screen from here. And the muscle that is also lighting up here with a larger arrow. You can see that. So this is another patient, and this is a cross-section or a slice of a thigh muscle. And it also shows muscle and fascial swelling in scleroderma myositis. And the area of muscle and fascial involvement is highlighted by the blue arrows. So if you get all this information from a muscle MRI, I think that's the preferred test that patients like. It's non-invasive, and it does not involve all those needles poking into muscles. And it gives you an idea about, if I were to do a muscle biopsy, which muscle group should I go after? Because that lights up on the MRI. So study was conducted using the Canadian Scleroderma Research Group database. About 1,100 patients with scleroderma were evaluated. It was found that about 6% had an elevated CK. Not everybody have clinical manifestation of myositis, but the following associations were noted. So these were male patients more often than females, those with diffuse scleroderma, They often had tendon friction rubs, which we'll talk about later. And they also had involvement of either the lungs or even the respiratory muscles like the diaphragm, causing the vital capacity to be reduced to less than 70%. And the antibodies typically associated are U1-RNP and SCL70 or topoisomerase antibody. Survival is affected in patients who have scleroderma myopathy with elevated CK, mostly due to not necessarily from the muscle disease, but they also tend to have other manifestations of the disease like interstitial lung disease, pulmonary hypertension, and cardiac muscle involvement, heart muscle involvement. So prognosis, on the other hand, in the inflammatory subset tends to be relatively good. Most scleroderma myositis patients improve with treatment. The myositis subset, not the one that have bland myopathy, which usually does not cause that degree of muscle weakness or elevation of the CK. So in a study, 35 patients with muscle biopsy proven myositis associated with scleroderma were investigated. So after a median follow-up of 4.5 years, 69% showed complete or partial remission of myositis. So if you can select the patients who have an inflammatory myopathy, treat them as the same way as you would treat somebody with polymyositis or dermatomyositis, the other forms of autoimmune rheumatic diseases, and they tend to respond well in that subset of patients. And the prognosis is good. And the mainstay of therapy to start with, you would be using steroids. And there's a word of caution here, using high-dose steroids in scleroderma patients. There's a concern of precipitation of renal crisis, but do it cautiously if you have to use steroids. And along with it, a second drug is often needed from the beginning, which could be either methotrexate or azathioprine or mycophenolate, or even intravenous immunoglobulin. So the last one is typically used for patients who are having difficulty swallowing because of involvement of the striated muscle of the esophagus. Also those who have respiratory muscle weakness, like diaphragmatic and intercostal muscle weakness, you might consider using IVIG, at least in the beginning, first few, maybe 3 to 6 months. And when the patient stabilizes, you can maintain the remission with the oral medications like methotrexate or azathioprine. Bone disease, we are moving on to bone disease. Good with time? Okay, so bone disease, acroosteolysis, as I mentioned, loss of bone at the tips of fingers and toes, and repeated bouts of inadequate blood flow to the fingertips from severe Raynaud's attacks leads to this dissolving or resorption of bone and shortening of the fingers. This is obviously a very difficult condition to treat. The most common symptom is pain at the tips of the fingers and toes. So patients have difficulty typing. The skin is very close to the tip of the bone. There's loss of pulp tissue. And there can be severe Raynaud's in these patients and digital ulcers as well. So X-rays are useful for the diagnosis. No specific treatment to regenerate bone. In cases where there is both acrosteolysis and decreased blood flow, like severe Raynaud's, we can consider using the same treatment for Raynaud's with the hope that it will improve the blood flow and slow down the progression of this condition. So this is what acrosteolysis looks like. This should be all rounded at the tip of this finger. And as you can see, it's tapering forward because of dissolving of bone. And this is another example where the bone looks kind of irregular at the tips of fingers. So this is a patient of mine, and this was published, who has, as you can see, you have the distal fingers are all missing in this particular patient. So you can see normally you should have 2 creases in the fingers. This patient only has 1 because all this, the tips of the fingers have been lost because of this chronic acroosteolytic process that shows on this X-ray. This is another patient showing the same pathology. The tips of the fingers are missing, and because of chronic ischemia. Osteoporosis is a bone disease that develops when bone mineral density and bone mass decreases and when quality and structure of bone is compromised. And it's been found that osteoporosis is more common in patients with scleroderma compared to the general population. It leads to decrease in bone strength and increase in the risk of fractures. So most commonly seen in postmenopausal women, and it develops normally in the normal population, 3 to 51% of patients, more common in scleroderma patients than in the general population. older age and low body weight for whatever reason are increasing the risk factor for osteoporosis. And it tends to be associated with calcinosis. Research has shown that same patients who get calcinosis, which we'll talk about later, also tend to get osteoporosis. So the treatment of osteoporosis, obviously, we would have to try to avoid steroids or minimize the use of steroids, but calcium and vitamin D in all patients, and these are the approved drugs for osteoporosis treatment, the bisphosphonates and parathyroid hormone analogs, and also we have denosumab, and we do not have time to go into detail on all these different therapies. And the newest addition is romosozumab or Evenity. So based on the patient, we decide which is the appropriate drug. And caution, obviously, scleroderma patients with significant esophageal dysmotility should be careful with oral bisphosphonates like alendronate or risedronate, like Fosamax or Actonel are the trade names. They have been associated with pill esophagitis. So if you have to treat somebody's osteoporosis, use the intravenous form of bisphosphonate, which is Riclast, which is given annually. And then they can get stuck. So keep that in mind when you're giving a bisphosphonate by mouth. They have to take it on an empty stomach, first thing in the morning with a whole full glass of water, and they cannot eat or drink anything for 30 to 60 minutes after that, and they should be upright. So that it goes down with gravity, because lack of motility of the esophagus, these pills get stuck in the esophagus and they can cause pill esophagitis. It's an irritating condition and it can cause ulceration of the esophagus. Tendon involvement. Tendon involvement is common, 36% with early disease and 20% in all scleroderma patients. Can occur adjacent to different joints. In the wrist, flexor tendon involvement can lead to carpal tunnel syndrome. So we talked about this earlier. We have the tendon sheath, and we have this yellow streak here. I think the next figure shows it better. So these are all the tendons, and this is the median nerve. So when the tendons get inflamed with fluid around the tendon sheath, it presses on the median nerve, causing carpal tunnel syndrome. So that's something that should raise the alarm in somebody who has Raynaud's and carpal tunnel. Think about scleroderma early in the course of the disease. This is another patient that shows that swelling on the back of the wrist, and that patient has this fluid on the ultrasound of that tendon. And here, if you do a cross section here, you will see that there is thickening of the tendon sheath because of inflammation. Tendon friction rubs is another manifestation of early diffuse scleroderma. You don't see it in limited disease. So seen in 36% of patients with early disease, 20% of patients with more established diffuse scleroderma. It's an early and painful condition associated with active severe disease. And there is fibrin deposition around the tendon and in the tendon sheath. So when you're moving the joint, you can feel what feels like Velcro or squeaky feeling or purring of cats. So patients describe differently what they feel. It's not the same thing as a crepitus on a joint. It's a little away from the joint on the tendon, you feel it. That's why it's called a friction rub. So affected tendons are knees, wrists, fingers, and ankles, and more commonly in early diffuse scleroderma patients, and mostly seen in patients with RNA polymerase 3 and SCL70 antibodies, which are typically antibodies associated with diffuse scleroderma. So these are the different locations. I understand these slides will be available later on. So all these are the tendons that can be affected, as I said. So this is an MRI scan. So a tendon friction rub is felt in front of the ankle called the tibialis anterior tendon. So MRI scan shows infiltration of the fat in front of the ankle and adjacent to a tendon in front of the ankle joint. So that's how it looks like. You can see it there, the arrow shows it. And this is the cross section also shows it there. Flexion contractures, this is another serious problem, difficult to treat. So they result from permanent tightening or shortening of the structures around a joint due to fibrosis. And this can be fibrosis of the skin, the joint, the capsule of the joint, tendons, muscles, and nearby tissues. The range of motion are significantly reduced or lost. and joints become very stiff and fixed in a flexed position. And they can sometimes appear early in the course of the disease, especially in patients with diffuse scleroderma. And small joints more commonly affected than larger ones like elbows, shoulders, knees, ankles. So mostly seen in hands, fingers, wrists, and you can see flexion contractures typically of the fingers. So this is a patient showing that the patient is unable to straighten the fingers because of the contractures. This two of my patients kind of very similar, and this is early in the course. They are unable to straighten their fingers because of the contractures. This is the X-ray, and what it shows like, this is another of my patient. You can see the patient is unable to straighten the fingers. This is a side view showing the contractures. And calcinosis is another manifestation, occurs in 25% of patients, extremely troublesome, causes pain and disfigurement. Calcinotic deposit can break through the skin and drain. Could be either chalky white material or toothpaste-like material. They can get inflamed and infected, and widespread calcinosis can be seen in some patients, lead to significant disability. Deposition of calcium hydroxyapatite, that's the composition of calcinosis. That's the particular salt of calcium called calcium hydroxyapatite. It deposits in the skin and soft tissues, typically in the hands, wrists, elbows, sometimes buttocks, and even the trunk. Has been associated, and this study shows, with ischemic digital ulcers and osteoporosis. Same patients also tend to get those two complications, and results from inflammation and lack of blood supply. That leads to this dystrophic, we call it dystrophic calcification. This is what the calcinosis looks like here. So you can see the arrow shows the calcium deposits in this particular finger. And the same patient, as you can see, also has acrosteolysis in a different finger. So sometimes it can be subtle, that can be only picked up on x-rays, and the patient may not be complaining of much symptoms. As you can see here, all these calcium deposits. But this is a patient who had severe, calcinosis. This patient had PMSCL antibody, where calcium deposits are much more commonly seen. And you can see that is trying to break through the skin. And this is another patient with calcium deposits that you can see. Sometimes these calcium deposits go just under the skin and can break through the skin. So not all ulcers at the tips of fingers are ischemic ulcers. So if you are going to give them vasodilator therapy, it may not be that effective. You can see this is skin breakdown from underlying calcinosis. This is another unfortunate patient that I lost maybe about 5 years ago with widespread calcinosis in the setting of scleroderma, anti-SCL70. So that's the right shoulder, left shoulder, and the buttocks are entirely covered with calcium. It's called calcinosis universalis. Unfortunate, and because there is no proven therapy. So I was given a topic to talk about where there's not a whole lot of proven therapy, not enough research has been done as to what can be done to help. So the treatment is mostly symptomatic. So try to improve the blood flow, because if Raynaud's is triggering the tissue injury, causing the calcinosis, try to improve the blood flow, aggressively treat the Raynaud's. When they are draining, they might get infected and antibiotics may be necessary, and also local wound care may be necessary. And sometimes when they cause severe pain, affect hand function, get infected, can be surgically removed. Obviously that's the best treatment. There is a chance of recurrence, but it doesn't always happen. And pharmacologic therapy, a whole array of different medications have been tried, starting from calcium channel blockers to bisphosphonates to sodium thiosulfate, which we have been currently using topical in a form of like a cream that is prepared by our compounding pharmacy, but sometimes they can be injected around the calcium deposits, or even given intravenously in those who have widespread calcinosis. For inflamed calcinosis, colchicine or minocycline can be used to reduce the inflammation, and other agents that have been tried with mixed results, IVIG, infliximab, which is a TNF inhibitor, and Rituxan. And then this is a patient with calcium deposit on the elbow that I showed you earlier. This is what was done. So she had it surgically removed, that long incision. She feels happy about it. Hopefully it stays that way. Yeah, and fibromyalgia is the last thing that we are going to talk about. So most common cause of generalized musculoskeletal pain in anybody, in women mostly between the ages of 20 to 55 years, and affects 2 to 3% of the general population, and manifested as chronic widespread pain, severe fatigue, sleep disturbance, and cognitive impairment. And this is a concomitant diagnosis rather than all part of scleroderma, since it is more commonly seen in people with autoimmune rheumatic diseases. So other symptoms are irritable bowel syndrome, chronic headaches, interstitial cystitis. It's a debilitating condition with no cause and no specific disease modifying therapy that alters the natural history of the disease, and is thought to be a disorder of pain regulation or central sensitization. Some patients also have other concomitant pathologies like obstructive sleep apnea, restless legs, etc. Scleroderma, there are multiple sources of pain. So before we say somebody has fibromyalgia, we have to make sure there's no explainable causes like severe Raynaud's, digital ulcers, inflamed calcinosis, gastrointestinal problems. So in one study, it was found that 85% of patients with scleroderma reported pain, and fibromyalgia, as I said, is a common condition, can also affect scleroderma patients. It would be critical to differentiate pain from fibromyalgia from common disease manifestations of scleroderma. The treatment is mainstay is non-pharmacologic, so graded exercise program, adequate restorative or refreshing sleep, stress reduction, addressing concomitant sleep disturbance such as sleep apnea. And then there are some approved medications that can be used like Cymbalta or Savella or even Lyrica. These are the FDA-approved medications for fibromyalgia, can also be used for chronic pain, even in non-fibromyalgia patients. So treatments for musculoskeletal manifestations of scleroderma, no randomized controlled trials, as I said, have been conducted specifically to address this. Also necessary to develop outcome measures for these manifestations. Data have been derived from studies in rheumatoid arthritis and other autoimmune rheumatic diseases. These treatments can help address some of the musculoskeletal manifestations, not all of it, in scleroderma, especially the inflammatory arthritis and the myositis. So pharmacologic treatment choice should also consider presence of other organ involvements, which might be a contraindication to use certain class of drugs like skin, lung, or gastrointestinal tract. And then non-drug measures are important. We heard about, Dr. Poole, and the physical therapy and occupational therapy plays a very important role. So physical therapy can help strengthen core muscles, address muscle contractures through active and passive range of motion of joints. Patients benefit from aerobic and resistance training, paraffin wax treatment, and other therapies for the hand and for the face can be effective. And you may want to look up on the websites or at least consult your local physical and occupational therapy therapist to hear about what options are there. And non-steroidal anti-inflammatory drugs can be used for inflammatory arthritis and pain. These are over-the-counter ones on top, and then some additional ones are prescription NSAIDs. However, be careful with the gastrointestinal manifestations of scleroderma. Also, long-term use can be associated with kidney damage, cardiac, heart failure worsening. Some of these NSAIDs affect liver function too, but the main concern is GI manifestations can be made worse, like esophagitis. If they have watermelon stomach, that can bleed, and they can actually, cause even rest of the GI tract can be affected from NSAIDs. Topical NSAIDs are obviously better and more, preferred, like over-the-counter Bengay or Icy Hot or Aspercreme, Biofreeze, Voltaren gel. You don't have to worry about the systemic side effects. So the inflamed joints, you can apply those, followed by local heat, and that might be helpful. Steroids, you have to be careful. They can help treat inflammatory arthritis and myositis, but prednisone at higher doses, like more than 15 milligrams a day, puts you at risk of scleroderma renal crisis. So that class of drugs have to be carefully used. So please use caution, especially in patients with early diffuse scleroderma, especially with RNA polymerase III antibodies, where the risk of renal crisis is the highest. Methotrexate, usually the first-line therapy for inflammatory arthritis, such as rheumatoid arthritis, can be used for musculoskeletal complications like myositis and inflammatory arthritis. Also been studied in skin thickening in scleroderma, and also in inflammatory muscle disease. So patients on methotrexate need to get regular blood counts and liver function, can cause fatigue, mouth ulcers, and hair loss. And obviously, you cannot be using it if you are planning to get pregnant. And it's a teratogen, so it can cause fetal damage. Plaquenil is a second-line therapy, or hydroxychloroquine, for scleroderma-associated inflammatory arthritis. Patients who do not respond adequately or cannot tolerate methotrexate, hydroxychloroquine can be added or substituted. And studies showed, this is a Canadian group of rheumatologists, where methotrexate as the first-line therapy was ineffective. The consensus opinion was you can consider steroids, which is a study published from 2012, a long time ago. But hydroxychloroquine is also an option in that subset. Leflunomide or Areva can be used. Small studies show it's a drug that is used for treatment of rheumatoid arthritis, can also be effective. Intravenous immunoglobulin, small studies described improvement in skin disease, gastrointestinal manifestations associated with scleroderma, also can be used in myositis or inflammatory myopathy. But one study also showed the beneficial effects of IVIG inflammatory arthritis, but it's a small study of only 7 patients. And all these parameters of evaluating effect on the musculoskeletal system were statistically better in those who received IVIG. The last 2 slides, so tumor necrosis factor inhibitors, these are, revolutionized the management of rheumatoid arthritis, like drugs like Humira and Enbrel can be used, but there is some concern we will talk about. So these are the FDA approved TNF inhibitors. Enbrel and Humira are the better known, but there are some others on the list. Small observational studies show inflammatory arthritis showed some improvement. However, there is concern about the possibility of worsening of pulmonary fibrosis. So there is some published literature on that concern. So keep that in mind when you're considering this class of drugs. Are also contraindicated in patients with MS, multiple sclerosis, and congestive heart failure. There's a risk of severe infections and reactivation of hepatitis B and TB. So you should screen patients for these infections before starting them on it. And then there is a potential risk, a small risk of malignancy, but it is mostly risk of lymphoma and melanoma and non-melanoma skin cancers. Patients who have had such history should not consider melanoma. Patients should not consider TNF inhibitors. And this is the last slide. Rituxan that you heard about in other presentations, helpful in the management of skin and lung involvement, can also be beneficial for the management of inflammatory arthritis. So if the patient has lung disease, skin disease, and inflammatory arthritis, this would be a good drug to use, as it will take care of 3 different problems all at the same time in patients with coexistent interstitial lung disease. And Orencia or abatacept, a study showed that it did not have any significant impact on their inflammatory arthritis. This was published more recently in 2020. And Actemra, which is now approved for interstitial lung disease in scleroderma, may potentially benefit inflammatory arthritis as well. So you can select this drug in those with ILD and inflammatory arthritis. That's everything. Thank you very much. Thanks for your attention. I'm not sure how much time I have.
Yeah, we're good. I'm just going to ask you a few questions from our online audience. At what point in disease progression, example, years from diagnosis, do you expect to see hand contractures?
Can you repeat the question?
Sure. At what point?
In disease progression, years from diagnosis, do you expect to see hand contractures? It tends to develop early sometimes in patients. I have had patients who had the symptoms of Raynaud's maybe for 6 months, and now already they are starting to show. And as time goes by, they get more curled up. This is more commonly seen in patients with diffuse scleroderma as opposed to those with limited. So limited patients tend not to have as much contractures. Diffuse patients tend to get more of those. What do you think about the very long-term use of hydroxychloroquine and meloxicam in systemic sclerosis? So hydroxychloroquine is a relatively safe drug. We have a very low threshold to prescribe it in inflammatory arthritis. As you know, it's the first line therapy for lupus patients. We use it in rheumatoid arthritis patients. You do a baseline eye exam to make sure there is not much going on. And the recommendation now is the dose is based on your weight in kilograms. And if you do the 5 milligram per kg daily, the recommendation now is you do not need to do any eye exam for 5 years and then go annually thereafter, because the toxicity, which is mostly for the eyes, is cumulative over time. So I have a low threshold to prescribe it if I believe patients have an inflammatory arthritis along with their scleroderma. And it can be added on to other drugs, like if they're getting mycophenolate for their skin and lung, you can add plaquenil to it. And it will take care of the inflammatory arthritis, which mycophenolate, in my experience, has not been the best drug for inflammatory arthritis in scleroderma. And the other part of that question is, do you happen to know a professional of your specialist in South Florida you could recommend? How do I respond to that? Yeah, I think we should probably get back to that.
Any questions from the audience?
Can you get a little closer? It's hard to hear you. Yeah, I talked about it. I mean, yeah, so it's much commonly seen in scleroderma patients. There might be multiple factors. Osteoporosis. That was your question. So the in-person audience question is osteoporosis more commonly seen in scleroderma patients? And the answer is yes. And there was a reference that I provided earlier. And so it has been found to be more common. And there thought to be multiple factors. Maybe, these patients have major gastrointestinal involvement. So absorption is an issue. They are underweight often because of that. And some of these patients are using steroids. So those might be factors. Leaving those aside, just having scleroderma, the risk of osteoporosis is higher, similar to those with patients with rheumatoid arthritis. So it's an independent risk factor for osteoporosis. And we talked about the treatment about it. So we try to avoid oral bisphosphonates like Fosamax or Actonel because of esophageal irritation and pill esophagitis. So if you have to use a bisphosphonate, we tend to use the intravenous form called Reclast. And we have other options like denosumab or Prolia that tends to be used. It's a subcutaneous injection every 6 months, which tends to do the job. Thank you. Take the microphone. Yeah.
That's okay.
You had mentioned blood flow being one of the maybe triggers or the causes of some of the damage that we're seeing, Raynaud's, calcinosis. I read a study that looked at the use of arm ergometry, so using like an arm crank to exercise the upper body to promote blood flow for Raynaud's. I don't think it was specific to scleroderma, but I wonder if you're familiar with that, because when we talk about exercise in general, we're not necessarily thinking about arm exercises, and that maybe could be beneficial to focus on arms.
Definitely, there's a role for physical and occupational therapy. So that would be something I recommend my patients to get involved early on in the course of the disease. So they do teach you how to do the hand exercises, finger exercises. So there are multiple functions of it. The contractures might be slowed down. Good studies are hard to do with this, interventions that are non-pharmacologic. So the evidence-based data is not as strong, but you might consider that to maintain the pliability, but also to improve the blood flow. It's even more proximal joints. So you're talking shoulders and elbows. So some blood flow improvement. So the Raynaud's is a result of, it's in scleroderma, Raynaud's is not the same kind of Raynaud's that you see in primary Raynaud's, which is a vasospastic process. This is more of a vaso-occlusive process. That means there's fibrosis and progressive narrowing of the blood vessels. So as a result, the exercise might help push through some blood, but I think we need better studies to actually look at it with a control arm. And whether it's ethical to do or not, but at least you can see whether it makes a big difference to the blood flow that can be objectively measured somehow, like laser Doppler perfusion, and see the treated arm with that intervention has better flow, and might that be helpful in reducing all these ischemic ulcers and calcinosis and acrosteolysis. So these are difficult to treat. Raynaud's, at least you use the conventional vasodilator therapy, and with the hope that it might slow down progression. But I'm not sure how much we know about therapy that will prevent it from happening. And could you predict who's going to get it? Not every patient gets it. I have patients with limited scleroderma for 10, 15, 20 years. All they have is Raynaud's and puffy fingers and acid reflux and nothing else. But there are others who tend to have rapid rate of progression, and all these changes happen in a short amount of time. So that's the part that, personalized approach to every patient is unique in that sense. Any other questions?
Thank you. I wanted to get more insight on the restrictiveness and range of motion. Is that more so the myositis that's at work, or more of the scleroderma, particularly in the shoulders range of motion and the ability to squat, bend, and pick up things from the floor? Is it more on the myositis side or the scleroderma side?
Are you getting good exercise? So there are two components to it. So the range of motion of maybe the fingers and toes and the more distal parts of the extremities is more a fibrotic process affecting not only the skin, but the joints, including the tendons and the tendon sheaths. So that's not so much of a myositis aspect. The proximal extremities like the shoulders and the thighs and buttocks, a part of it is myositis. But as I said, there's a bland form of myopathy that happens in some patients with scleroderma. And if you did a muscle biopsy, there's not much inflammation. They have mostly fibrosis. So it is hard to tell which particular subset we are dealing with. If the muscle MRI lights up significantly, there would be indication there's myositis. You do a muscle biopsy, and it shows a lot of inflammatory cells. You can make a case in that subset of patients to use immunosuppressive therapy, cautiously, obviously, with steroids. But on the other hand, if it is just contractures, I have patients who develop contractures, that means in tightening of the skin and the tendons and the ligaments, and the range of motion is significantly compromised. Their muscle enzymes are not high. The MRI doesn't light up. In that case, it's more of a fibrotic process. So it's customized. You take case by case and decide how to treat it. Sure. Any other?
We're good here. Yeah. Thank you so much. Thank you, Dr. Chatterjee. It was a pleasure.